Hi, everyone. See that some people are still joining, so we will get started in another minute or so. Hi, everyone. Good morning, good afternoon, and good evening. Thank you all very much for joining us today for the second session of Momentum's webinar series, Strengthening Analysis and Use of Routine Health Facility Data for Maternal, Newborn, and Child Health. My name is Zach Crosser, and I am a Research Monitoring and Evaluation Advisor with the Momentum Knowledge Accelerator. Before we begin with today's session, there are a few housekeeping items that we'd like to cover in order to provide everyone with the best experience possible on today's webinar. Next slide, please. First, please note that today's webinar and all other sessions during this series will be recorded and posted to the Momentum website. If you missed the first session, or if you're not able to attend any of the remaining sessions in this series, you'll be able to access the recordings and materials shortly after each session takes place. My colleague Emily will share a link in the chat to the webpage where you can access the recordings. During today's session, we will have some presenters who are speaking in English and some will be speaking in French. We have simultaneous interpretation available for today's session, so I'd like to invite you now to take a moment to select the interpretation icon at the bottom of your screen. It looks like a little globe and it has the word interpretation under it. And then from there, you can select the audio channel that you would like to listen in on for today's session. If you stay in this main channel, you will hear the presenters speaking directly. We have two of our presenters today will be speaking in English and one will be speaking in French. So you can click on the interpretation icon and then select the language that you would like to listen in on for today's session. On a related note, the slides that will be presented on the screen today will appear in the language in which the presenters are speaking. My colleague Emily will also share links in the chat to English only and French only versions of the slides that you can use to follow along on your own, along with the presentation. Lastly, there will be time for questions and answers at the end of today's session. So you can click on the Q&A icon at the bottom of your screen to submit any questions that you may have. We'll do our best to respond to the questions either directly in the Q&A or during our questions and answers period at the end of today's session. With that housekeeping out of the way, I think we are ready to begin. Next slide. For those of you who weren't able to attend session one, the purpose of this series is to introduce participants to resources and tools that you can use in your work to strengthen the analysis and use of routine health facility data for maternal, newborn, child, and adolescent health programs. Routine health facility data is an important source of information for decision makers to understand service utilization and service quality so that they can identify problems and then make evidence-based decisions on policies and resource allocation. In an effort to strengthen the analysis and use of health facility data for MNCAH programs, the World Health Organization developed a guidance document and an accompanying resource package that can be used for capacity strengthening in workshop and webinar settings such as this one. The guidance document describes a catalog of indicators for MNCAH that can be monitored through routine health information systems data, and it also provides guidance on possible analyses and visualizations for the indicators. The document also includes considerations for program managers and interpreters for program managers for interpreting and using the data for decision-making. This webinar series is intended to introduce you to the guidance document and the accompanying resource package. While Momentum contributed to these resources, we did not lead the development process. So unfortunately, we won't be able to answer any questions you have around the development process or questions about why the resources are structured the way they are or why certain things were included or excluded. My colleague Emily will share an email address in the chat that you can reach out to with these sort of fundamental questions about the WHO guidance. Next slide, please. Each session in this webinar series will have a similar structure and will include the same core components. In each session, we'll introduce key concepts related to analysis and use of routine health facility data. And we will also hear presentations from Momentum staff from different awards on how they have put these key concepts into action in their work. We will also highlight different tools and resources, mainly focusing on the WHO toolkit, but we will also highlight some other outside resources throughout the sessions as well. This is the second session of a 5-part webinar series. The first session provided an introduction to health facility data, discussed different types and sources of routine data, reviewed the list of WHO recommended indicators for monitoring MNCH programs, and discussed considerations for introducing indicators into country HMIS. During today's session, we'll look at data quality considerations and approaches to improve data quality. Session 3 will be held on September 5th and will focus on data triangulation and analysis. Session 4 is on September 12th and will look at data interpretation and data use for decision-making. And finally, our last session will be on September 26th, and this will be a shorter session that focuses on data visualization. Next slide, please. Today's presenters include myself, as well as Vishal Agarwal, who is a monitoring and evaluation specialist with Momentum Routine Immunization Transformation and Equity, or MRIT, and Carmel Toupé, who is a monitoring and evaluation coordinator with Momentum Private Healthcare Delivery, or MPHD. Next slide, please. During today's session, we will provide an overview of WHO's data quality framework and review the dimensions of data quality. We will also highlight tools and resources that can be used to support work to improve the quality of routine data for MNCH. And we'll also hear from 2 different Momentum Awards about how they have worked to improve data quality in their respective areas of focus. Vishal will be presenting on MRIT's experience working with the Ministry of Health in India to improve the quality of routine immunization data. And Carmel will be presenting on MPHD's experience conducting data quality assessments with private healthcare facilities in Benin. Next slide, please. So we will begin with a look at the WHO Data Quality Assurance Framework. Next slide. WHO has developed a toolkit for routine health information systems data that is meant to address some of the most common challenges related to RHIS data, such as complex and unharmonized reporting requirements, fragmented data systems, poor data quality, and capacity gaps for analyzing and using RHIS data. The toolkit emphasizes standardization, integration, and a focused approach to data analysis. It aims to focus the analysis of RHIS data on a limited set of indicators using recommended standard analyses, visualizations, and dashboards, and to provide guidance on the use and interpretation of data. The toolkit consists of 3 types of resources. First are the resources that are displayed at the top of this graphic. These resources are for standards for measurement and analysis of RHIS, including general principles, core indicators and metadata, and the Data Quality Assurance Toolkit, which we'll be looking at a little bit later today. This broader RHIS toolkit also contains guidance for planners and managers, including integrated health service analysis at the facility, district, and national levels. At the bottom of this graphic, the program-specific guidance documents and training materials are listed. There are currently program-specific guidance documents and resources for HIV, immunization, TB, malaria, rehabilitation, and MNCH, with more programs to be added in the future. This webinar series focuses on the program-specific guidance for MNCH primarily, but today we will also be looking at the general guidance for data quality assurance. Next slide, please. The WHO Data Quality Assurance Toolkit is designed to support countries in assessing and improving the quality of RHIS data. Many different tools and efforts for examining the quality of health facility data have been developed over the years, but many of these efforts were not well coordinated. Having independent, uncoordinated assessments carried out separately by different actors made it difficult to assess the capacity of health facilities to produce quality data more holistically. The WHO Toolkit for Data Quality Assurance builds on these efforts and provides guidance for a harmonized approach to measuring and improving data quality. The DQA Toolkit consists of 3 modules. Module 1 outlines the framework and data quality metrics. Module 2 provides guidance on conducting desk reviews. And Module 3 provides guidance on conducting site assessments at facilities and districts for data verification and system assessment. There's also a working version of the 4th module, which focuses on community health data available on the WHO website. All of these modules include guidance documents, implementation guides, training materials, and standardized tools in Excel and DHIS2 that can be used for conducting data quality reviews. The aim of these resources is to provide a common language and standard metrics for the measurement of data quality. The DQR methodology, which is described in detail in Module 1 of the toolkit, comprises 2 separate processes that are described on this slide. The first process is a desk review that looks at the quality of data that has been aggregated and reported. The desk review can be done either as part of your routine data quality checks that happen on a regular schedule, or as a part of a discrete assessment. The second process in the DQR methodology is a site assessment of the data quality that requires visits to health facilities and district offices to verify the sources of data from different registries and data collection tools. The site assessment can either be part of a routine data quality assurance cycle, for example, if it's linked to regular supervision visits, or it can also be part of a discrete assessment. Next slide. The data quality review examines the quality of data by applying data quality metrics to indicators that are being reported from a health facility. Since there are usually many indicators reported from health facilities, it's probably not going to be feasible to examine the quality of data for all reported indicators. So we usually need to select certain indicators to be included based on the purpose of the data quality review. In general, indicators that are selected to be included in the data quality review should be indicators that are important for program monitoring and evaluation. They should be tracer indicators, meaning they can be, the results can be traced from the source all the way to the national level, and that those results are indicative of data quality for all indicators within a program area. The indicators should be widely available and expected to be reported from most or all of the facilities that are offering services in the program area. And the indicators should be straightforward to review, to verify the data for. The idea behind that point is that we want to reduce the burden of collecting the data for our review itself, and we also want to minimize the chance that we ourselves are making an error. Next slide, please. The Data Quality Assurance Toolkit groups data quality issues into 4 different dimensions. First is the completeness and timeliness of data. Second is the internal consistency of reported data. Third is an external comparison or cross-checks with other data sources. And fourth is the consistency of population data that is used. So we'll look at a little bit more at each of these 4 dimensions now. Next slide, please. So when we're assessing the data completeness and timeliness, we're looking to see whether all of the entities that are supposed to report are actually doing so. And we're also looking to see if reports were submitted on or before predefined deadlines. So this applies to health facilities that are reporting to districts, as well as districts that report to regional or provincial levels. The metrics that we use to assess data completeness and timeliness are things like, we'll look at the percentage of facilities or districts that have actually reported. And out of those that were out of the reports that were received, we also look at what % of those reports were received ahead of the predefined deadline. And when we're looking at completeness and timeliness, we also look at the completeness of individual indicator data rather than just did this facility or district report. We also look to see what % of data elements for specific indicators are reported and that are reported with non-zero or non-missing values. Next slide, please. When we're looking at internal consistency, we're looking at the coherence between the same data items at different points in time. We're also looking at the coherence between related data items. And we also compare the data in a source document to the data that's aggregated in reports. The metrics that are used to assess internal consistency are things like looking for the presence of outliers or extreme values, assessing trends in the data to see if the data is consistent over time, looking at the consistency between indicators that have a predictable relationship with one another, and looking at the consistency between the data that is reported compared to the data in the source documents. Next slide, please. The third dimension looks at the level of agreement between 2 different sources of data that are measuring the same indicator. For this, you would usually compare the RHIS data to data that's collected through a population-based survey like the DHS or MICS. The RHIS data can also be compared to pharmacy records or other types of data to ensure that the 2 sources fall within a similar range. Next slide, please. The fourth dimension tries to determine the adequacy of population data that's used in the evaluation of health indicators. Population data usually serves as the denominator in the calculation of a rate or proportion. So this data quality measurement looks at the consistency of the population data that was used for the calculation of the indicator compared to another source of population data. If the 2 population estimates are dramatically different, then the coverage estimate for the given indicator could be very different, even though the programmatic result is the same. So for this one, the higher the level of consistency across the different population estimates, the more likely it is that they represent the true population value. Next slide, please. In order to facilitate the process of conducting data quality reviews, the WHO toolkit includes standardized tools in Excel and DHIS2. The Excel tool helps to automate the analysis of data quality metrics across the 4 domains of data quality based on inputs that are provided by the user. Because the Excel tool does require that manual entry of data by the user, it's recommended that this tool is used for discrete desk reviews rather than routine checks of data quality. And while this Excel tool was developed for the purpose of conducting cross-cutting desk reviews of data quality across multiple program indicators, it can also be used to conduct program-specific desk reviews of data quality that only look at, for example, the WHO recommended indicators for MNCAH. The DQR metrics have also been incorporated into DHIS2 as a part of the WHO Data Quality app. This app can be used for cross-cutting or program-specific discrete assessments, and it can automatically generate data quality reports. The WHO Data Quality app is the tool that's recommended to be used for continuous monitoring rather than the Excel tool, since it allows users to detect and make corrections to errors in aggregation and reporting in real time or nearly real time. Instructions on how to set up and use these standardized data quality review tools are available on the WHO website. Next slide, please. The DQR framework includes recommended benchmarks and cutoffs in the measurement of data quality, depending on the specific metric. A benchmark reflects the desired or acceptable level for a specific metric to reach, and a cutoff flags units that have data anomalies that need further examination. The benchmarks allow countries to compare themselves to a standardized benchmark, but countries also have the option to tailor the benchmark to their own context. For example, a reporting rate of 80% might be acceptable in a country with historically low reporting performance, but it would not be considered acceptable in other countries that have more mature systems and reporting rates that are usually closer to 100%. Cutoffs are used when we're looking at the consistency of data over time. They compare the current value for a district or some other subnational unit to its expected value. The expected value can simply be the average value over the last 3 years. And if there's a plus or minus 33% difference between the current value and the expected value, then the district is flagged for additional scrutiny to see if any data quality issues are causing that variance. Module 1 of the DQA toolkit defines the benchmarks and cutoffs for each of the 4 dimensions of data quality for some of the WHO recommended core indicators. Next slide, please. So during today's session, we've taken a really quick look at Module 1 of the Data Quality Assurance Toolkit, which introduces the DQA framework and metrics. We won't dig into this module any further, and we also won't be looking at modules 2 or 3 during today's session. Modules 2 and 3 go into much more depth on the process for conducting desk reviews and site assessments of data quality. They also include training materials, tools, and guidelines and instructions for using the tools. My colleague Emily will share a link in the chat that you can use to access the DQA toolkit and to learn more about it. Next slide, please. So now we'll spend just a few minutes pivoting to the program-specific guidance for MNCAH program managers. And we'll just take a quick look at what's inside some of the program-specific resources around data quality. Next slide, please. So the document that this whole series is based on is called Analysis and Use of Health Facility Data, Guidance for Maternal, Newborn, Child, and Adolescent Health Program Managers. This guidance document is accompanied by capacity strengthening materials that are broken down into 7 presentations. During the first session of our webinar series, we took a look inside the first 2 presentations, which provided an overview of the different types and sources of health data and introduced us to the WHO recommended indicators for MNCAH. Today, we'll take a look inside the 3rd presentation, which covers data quality considerations for MNCAH managers. Next slide, please. The objectives of presentation number 3 are to describe common RHIS data quality problems and explain the importance of having good data quality for making decisions. One thing I'd like to note here is that the resources in the WHO Data Quality Assurance Toolkit that we just reviewed earlier and the program-specific resources for MNCAH have different purposes with regard to the topic of data quality. The DQA toolkit is intended to provide detailed guidance related to conducting data quality reviews, and the audience for those resources is people who are or will be conducting program-specific or cross-cutting data quality reviews. The MNCAH-specific guidance, on the other hand, that we're about to look at, looks at data quality from a different angle. While undertaking data quality reviews and assessments might fall within the scope of HMIS officers or data managers or analysts, program managers and decision makers at all levels need to be familiar with data quality problems so that the problems can be identified and corrected. The MNCAH program guidance on data quality is meant to introduce program managers to basic data quality concepts that they need to understand in order to be able to make evidence-informed decisions. Next slide, please. In the program-specific MNCAH guidance and resources, we still get an overview of the 4 dimensions of data quality, as well as definitions of what those dimensions are. But in these resources, we also get examples that illustrate what data quality issues might actually look like when you're reviewing data. And they also cover why it's important for program managers to interpret MNCAH data through a quality lens. MNCAH managers should be reviewing programmatic data routinely. These types of data quality checks may involve comparing current data with data that was reported in previous time periods in order to identify trends, or by comparing performance indicators in different geographical areas. And then when inconsistencies are identified, the program manager should investigate the data in more detail by drilling down to the most granular level possible. Often, data anomalies can be masked by aggregation to higher levels, and the problems may not become apparent until the lowest levels of data are inspected. Anomalies in the data may not always be the result of data quality issues, however. They can be because of actual but expected changes in service utilization. For example, we sometimes see that service delivery is interrupted by stockouts of commodities or events in the country or community, such as health worker strikes or extreme weather events. These types of events might affect the consistency of trends in service indicators. So when potential data quality issues are identified, it's also important to consider the context to guide your additional investigation. So overall, the first half of the slides in the MNCAH specific resources on data quality provide an overview of the dimensions of data quality, along with these sorts of helpful graphs and tables that help to illustrate how program managers can interpret data quality through a quality lens. Next slide. So this is my last slide. And the other main component of presentation number 3 is to help program managers understand what can and should be done to address data quality issues. When issues are identified, program managers will need to understand the root causes. So why are these problems occurring? And then come up with an action plan to address them. So this slide contains an example taken from presentation number 3 in the toolkit that aims to help illustrate what this process might look like. In this example, we have the issues that's arising is that we're identifying outliers and errors when we're reviewing the data. And then when we're drilling down into the data, we see that to see the numbers at the lower levels, we learn that the errors are being introduced at the district level. Next, during a field visit, we learn that the regional level is not reviewing the data that's being submitted to them. Also during this visit, we learned that one of the reasons that the regional level isn't reviewing the data is that no guidance existed for them to conduct the review. So in this case, an actionable step to help address the data quality issues that we're experiencing might be to create an SOP for data review. Presentation number 3 in the MNCAH resource package concludes with a few of these sort of simplified high-level examples of how this process can occur for identifying data quality issues, then drilling down into their root causes before coming up with actionable ways to address the issues. So far during today's session, we've reviewed some of the concepts and tools that can be used to identify issues and improve data quality. And for the rest of today's session, we'll hear from Momentum Awards about how they have put these concepts and tools around data quality review into practice. Next slide, please. So I will now hand it over to Vishal to speak about MRHIS work to improve the quality of immunization data in India. Vishal, over to you.
Thanks. Thank you, Zach. Hi, good morning, good evening, and good afternoon, everyone. Next slide, please. So in this section of the presentation, we will discuss about the data quality assessment, what we have done in India so far. So the contents of this presentation is about the programmatic context of data quality assessment, some goals and objectives of data quality assessment, geography where we have done this assessment. After that, the methodology, what we have adopted for doing this assessment, the data collection tools which we have used for data collection and analysis, some findings of the data quality assessment, and finally the observations and recommendations after the DQS. Next slide, please. So as the program context of this data quality assessment, all of us already knows that the primary source of immunization data is health management information system in most of the countries. So, but the quality as the being a primary source of immunization data, the quality of this reported data is seldom systematically assessed against some standard protocols. And because of this lack of assessment, it hampers the identification of barriers to increase immunization coverage and to highlight the critical need for robust data management system in a routine immunization program. So our project goal was to strengthen the data quality so that it can be used for effective program management by improving the data quality and increasing the capabilities of health staff, supporting them in taking informed decision making and capacity building among the different local stakeholders about the routine immunization program. Next slide, please. Next. So as I said, the DQA goal was to strengthen the data recording and reporting system for increasing the immunization coverage. And our objective was to assess the quality of reported immunization data in the HMIS portal for 4 different key measures. What are those four different key measures? Like, one of them is availability, completeness, agreement, and consistency. So in the data quality assessment, these 4 components are being reviewed to assess the data quality. Here, the availability means physical availability of records and reports which are being used during the routine immunization data collections. Completeness of those records and reports. Completeness, I mean in terms of like all specified immunization related field in a particular record or report are filled or not. The third one is agreement. That means if 2 documents that were supposed to have the same data were identical or not, or there are some mismatches. And the fourth one is consistency. Like, consistency here means if the reported data follow the logic that is expected from an immunization system, whether it is followed that particular logic or not. And the second objective was to understand the strength and weakness of the immunization system in terms of data management. And the third and last one, to develop the data quality improvement plan so that for addressing all the barriers which have identified during the data quality assessment, how they can be improved and what will be the timeline to complete those activities. All of those can be envisaged in the data quality improvement plans. Next slide, please. So coming to the geography where we have done these data quality assessments. So the DQA reviewed, as the process, we have reviewed all the routine immunization related record and reports. We have conducted these DQAs in 4 urban NUHM cities, right? Government of India has given the mandate to JSI or JSI team to implement these efforts in 15 NUHM cities. Out of those 15 NUHM cities, we have conducted 4 data quality assessment in 4 different CEM cities. The period of data collection was from June 2023 to November 2023. It remains the same for all 4 CEM cities. And the data was collected during the period of February to May. And what was analyzed using an Excel-based tool, and the findings after the analysis were shared with the state and district health authorities as well. Next slide, please. So coming to the routine immunization data flow, what we have followed in India. So data generation is start with the routine immunization sessions, in which the tally sheet, we should say the tally sheet is the single source of truth that should be used for each and every session. That from the data from those tally sheets goes to the mother and child protection card, that is called MCP card, that is carried by the caregivers. And the same data from the tally sheet also goes to reproductive and child health register, that is called RCH registers. The tally sheet and the RCH register is maintained by the ANMs, and MCP card is carried by the caregiver. Next is monthly progress report. So the all aggregate data from tally sheet goes to the monthly progress report. Those monthly progress report is the primary source for data entry in the HMIS portal. And after these monthly progress report being prepared and submitted by the ANMs on a monthly basis, same data is entered in HMIS portal at UPHC or block level. Next slide, please. So this is the data flow. Like ANM records the vaccination details in tally sheet RCH register during the session. During the DQA, we have reviewed all the tally sheet. We have verified all the tally sheet, RCH registers, and other immunization related records for that particular period of time, that is June 2023 to November 2023. After that, ANM submits the record to the UPHC level, and UPHC is the place where the data gets entered in the HMIS portal. And on the same place, we have verified the HMIS reports and the hard copies of monthly progress reports also at UPHC level. Next slide, please. So this is the methodology what we have adopted for data quality assessment. So for this data quality assessment, we have actually considered the data quality assessment tool developed by the WHO and Gavi. And we have reviewed all those tools and make some context related changes according to India's immunization system. Based on that, we have prepared a different tool for data collection. The following records like tally sheet, RCH registers, monthly progress report in paper copies, and monthly progress report in e-copies like HMIS portal were assessed for 4 key measures like what I have discussed in previous slide, like availability, completeness, agreement, and consistency. All these records, tally sheet, RCH registers, monthly progress reports, and HMIS portal data, all these records were assessed for all these 4 key measures of data quality. Next slide, please. So how we have selected the assessment period. So what I have talked about, that we have selected the period from June to November. So our basic thing that the records and reports we have verified for a period of 6 months. The 6-month period, these are the 6-month period in which if we are visiting the field in the month of May, then we will select the data, we will select the period from October to March, because in the month of May, we are visiting the field, and it will take some time to stabilize the data for the month of April. So we can leave the month of April and May for the data collection, and we can consider the October to March data for our data quality assessment purpose. So in case of May month, we are visiting the field in May, we will consider the data from October to March for DQA process. Next slide, please. So these are some assessment steps for data quality assessment. To start with the compilation and verification of data from HMIS portal. So this is a desk job, and we can do this particular data collection, data download from HMIS portal even before the field visits. During the field visit, we can compile the data. We can do the data collection from tally sheets, RCH registers, monthly progress report, and any other paper-based records whichever we have found in the urban PHCs or our health facilities. So these are some data sources which we have considered during our data collection. So these tasks are for during the field visit. And the last one is sample validation in the community that we have done during the field visit as well. Next slide, please. So these are 4 key major indicators what we have discussed, like availability, completeness, consistency, and agreement. So a definition of these, like availability means the proportion of records and reports available out of the total number of expected records and reports. For example, if a health worker conducted 100 sessions in a particular study period, like from June to November, a health worker conducted 100 sessions, and tally sheet is a basic record which should be used for each and every RA session. Then out of 100 routine immunization sessions, how many tally sheets we can get from the health facility? So that is the proportion of records and reports for availability indicator. The next one is completeness. So here completeness means the routine, immunization related data are filled in that particular record and report or not. For example, in monthly progress report, all the specified immunization related data fields are filled or not. So those which have immunization related data is complete is our denominator out of the number of reports expected. So for example, we have reviewed the data for 6 months, and monthly progress report is the document which is maintained by the ANM on a monthly basis. So for 6 months, the denominator will be 6, and out of those 6 monthly progress report, how many monthly progress reports are found complete in terms of immunization related data fields? So the third indicator is consistency. Consistency, as I said, that it means whether the reported data follows a logical pattern, it follows a logic expected from an immunization system or not. For example, in a logical system, in a logical pattern, OPV first dose data, number of OPV first dose administered should be more than or equals to number of OPV third dose. If we aggregate the data at least for a 6 month. The fourth indicator was agreement. It means 2 different records and reports. Those are expected to have the same data, are identical or not, or there are some mismatches in those records. Next slide, please. So indicator 1, availability. We have reviewed this availability in tally sheets, monthly progress reports, and HMIS portal data. And as I said, the proportion of tally sheets which were physically found available for all immunization sessions conducted at the UPHC for the study period, that was our numerator out of total number of sessions conducted. So the number of sessions conducted was the denominator to get the availability of tally sheet. For the monthly progress report, the number of monthly progress report in paper copies were found physically available in the selected UPHCs. And the same for the HMIS data. Number of health facilities data in HMIS was found available out of the total number of facilities selected. Next slide, please. So the second one is completeness. So we have not reviewed the completeness for tally sheet due to the design, due to the limitation in the design. But we have definitely reviewed the completeness of monthly progress report and HMIS. So completeness here means, as I said, if a monthly progress report have all the specified immunization related data filled in that, it means that particular monthly progress report is complete. If there are some blank fields in the immunization related data, we have considered that particular monthly progress report as incomplete report. And the same for the HMIS data. If in the HMIS portal data, any monthly progress report is incomplete for any particular indicator in the specified immunization related field, it means that month for that particular monthly progress report is found incomplete. Next slide, please. Consistency. So as I said, the consistency means the logical pattern. So we have reviewed the consistency in monthly progress report of hard copies and in monthly progress report in HMIS portal as well. We have analyzed the data whether OPV1, number of OPV1 doses for a 6-month period is greater than or equals to OPV3. If this pattern, we have found this pattern, then it means that particular PHC is consistent for OPV and Penta. Otherwise, that particular health facility was not consistent for OPV and Penta. And same thing we have followed in HMIS portal data as well. Next slide, please. So in terms of agreement, we have done the different kind of agreement during the data quality assessment. We have different kind of records like tally sheets, monthly progress reports, RCH registers data, mother and child protection card. We have different kind of recording and reporting formats. And for the same, we have done different kind of agreement between two different documents or records and reports. The first agreement was aggregate of tally sheet data for all 6 months is matching with monthly progress report data or not. So suppose a health facility, a health worker has conducted 10 sessions in a month. So aggregate of 10 sessions data from tally sheet, are this data matching from the monthly progress report data, what he or she has submitted to the health facility or not? The next one is tally sheet data versus RCH register data. In this kind of agreement, we have noted all the beneficiaries in a particular month that have been reported in the tally sheet. And for the same month, we have noted all the beneficiaries which have vaccinated in a particular month from the RCH register data. And after that data collection, we have matched both the records that which beneficiary is available in both the sources. So for example, if Vishal is vaccinated for BCG in the month of November, as per tally sheet, then same Vishal's information should be available in the RCH register data for same date and for same antigen as well. So this kind of agreement we have done the tally sheet and RCH register data. The next one is monthly progress report and RCH. We have taken a full immunization as an indicator for this agreement. Like if a health worker has reported 30 full immunization numbers in monthly progress report, then that particular health worker was asked to show those 30 names in their RCH registers. So we have reviewed all 30 names and found that if all 30 beneficiaries have completed their vaccination schedule up to the 1 year within the first year of life, then we have considered that particular child as a full immunization child. Otherwise, if there is some discrepancy, then we have not considered that particular child as a full immunization child. The fourth indicator was a monthly progress report data with HMIS portal data. That should be the same because monthly progress report is the primary source of data entry in the HMIS portal. So that should be exactly same. It means that should be the 100% agreement in both of these sources. So the last agreement was RCH register data and monthly and mother and child protection card. Here we means that the data available in the RCH register, we have taken 8 to 10 beneficiaries or children data from the RCH registers. Whatever vaccination information is mentioned in the RCH register from BCG to measles first dose. And we have verified all those vaccination date at the doorstep of the beneficiary from the mother and child protection card. If that information matches with the RCH register data, it means there is an agreement. Otherwise, there is no agreement between these two sources. Next slide, please. So now we'll discuss about the data collection tools, what we have used during our data quality assessment. So this is a kind of summary of data collection tools. You can see that tool number DQA1. For this tool, we have the data source was session tally sheet or session registers in which session-wise numbers can be found during the data collection. Month-wise data posted by ANMs in the UPHC during the assessment period. So whatever the data source, either from tally sheet or register in which date-wise data or month-wise date-wise data posted by the ANMs in the for a complete assessment period. Second source was DQA 1.1. So it is quite different from one. From in DQA1, we are collecting only date-wise numbers for a particular health worker or a particular PHC. But in DQA 1.1, we are considering the beneficiary name. DQA 1, we are considering assessment period for whole 6 months, but in DQA 1.1, we are collecting the data only for the last month of our assessment period. So the difference is that in DQA 1, we are only collecting the numbers, and DQA 1.1, we are collecting the information by name and whatever the antigen is given to the beneficiary in that particular month. So the next tool is DQA 2, which is same as 1.1, beneficiary-wise information for all the antigen given to a particular date during our assessment last month of the assessment period. But the source to fill this document is RCH register or immunization register, in which a complete tracking of a particular beneficiary can be found in that particular source, RCH register. So the third source is monthly progress report that is maintained by the ANM, the aggregate number of all the sessions they have conducted in a particular month, and aggregate number is being compiled in that particular monthly progress report. That is a primary source of data entry for HMIS portal. The fourth data collection tool is HMIS portal, for which we have downloaded the data before our field visit, month-wise, antigen-wise aggregated number for a particular health facility. And the last one, DQ5 tool, is MCP card, that is Mother and Child Protection Card, which we have used during our community validation. As I said, we can get some names from RCH registers that what antigen is being given to a particular child, and we can verify those particular antigens at a doorstep or of the same beneficiary from the Mother and Child Protection Card. So these are some data quality data collection tools which we have used during the data quality assessment. Next slide, please. So now we can discuss about a specific tool. This is kind of an image of DQA1. You can see this is a kind of Excel format in which name of session site, date of sessions, tally sheet or due list were available or not, and the antigens, number of antigens given on a particular date. So this tool will be used to capture the session-wise number from session tally sheet or due list, or any other source in which the session-wise numbers we can found at the health facility. This tool need to be filled for all the ANMs posted, all the health workers posted at the particular health facility. Data should be collected for specified 6 months. In our case, the specified 6 months were from June 2023 to November 2023. And as I said, the source required to fill this tool was tally sheet or any kind of session registers in which date-wise numbers are available. So this is DQA tool 1, a snapshot of DQA tool 1. Next slide. So this is DQA 1.1. As I said, in DQA 1, we have collected only date-wise numbers for all 6 months of the study period. But in DQA 1.1, we have collected the beneficiary-wise data only for the last month of the study period. So this tool will be used to capture the name-wise information from the tally sheet or session registers. But the name-wise information need to fill for all the ANMs of a particular health facility. We have follow a pattern like name of beneficiary with name of father to avoid any kind of duplication in names. Source required to fill this tool is again same, tally sheet or session registers in which the name wise information and the antigen administered is available. In any case, this tool should not be filled from RCH registers. Only the source which we can use to fill this particular tool is tally sheet or session-wise registers in which name-wise information of a particular antigen given to the child on a particular date. No tracking is required of a particular beneficiary to fill this tool. Next slide, please. So again, the DQA tool number 2, sorry. So this is exact same replica of DQA tool number 1.1. The difference is only the source. which we require to fill this tool. In DQA 1.1, we have used tally sheet or session registers, but in DQA 2, we are using the RCH register or immunization register, in which all tracking of a particular beneficiary can be available. And the same, we have followed a same pattern like child name with the name of father to avoid any kind of duplication. Data should be collected for a single month, preferably for the last month of the study period. So we have collected the data from June to November. In our case, we have collected November month data for DQA 1.1 and DQA 2. Next slide, please.
Hi, Vishal. Quickly, sorry to interrupt. I just wanted to let you know that you have about 5 minutes remaining.
Oh, thank you. So data collection tool number 3, that is the source for this tool is monthly progress report, which is being compiled by our health workers. This is basically the aggregation of all the tally sheets. Source request to this field is monthly progress report, which is available at the health facility. Data should be collected for all 6 months. Next slide, please. So again, this is the replica of DQA tool 3. The only difference is that we can use this tool for HMIS data. The data which we have downloaded before the field visit from HMIS portal, we can fill that data in this particular tool. Otherwise, this is the same as DQA 3. Next slide, please. So this is DQA tool 5, in which this tool we are using for community validation, the 5 or 6 beneficiary which we have collected for data from RCH register, the same data which we are verifying from the MCP card at the doorstep of beneficiary. You can see the shaded columns. In these shaded columns, we have to fill the dates of a particular antigen given to the beneficiary as per the RCH registers. And then in white column, we can fill the date, what they have mentioned in the MCP card. Next slide, please. So this is the summary of data quality assessment process. Like tally sheets contain the individual level data from a single session, mother and child production card that is carried by the caregivers, reproductive child health, that is RCH register. This is available. That particular register contains the individual level data and available at the session site itself. Monthly progress report is available at the UPHC level. That is basically the compilation of data from all the tally sheets, aggregate numbers from all the tally sheets, and the HMIS portal data, which we have downloaded before the field visit of the DQA. So the type of DQA for tally sheet format, we have considered tally sheet for availability and agreement only. Mother and child production card, we have considered for agreement only, and same for RCH registers. But for MPR and HMIS portals, we have analyzed for availability, completeness, consistency, and agreement for all 4 indicators of these 2 sources. Next slide, please. So coming to the findings of data quality assessment, I will not go into the details. For these findings, you can see that this is the availability of tally sheets. We have conducted these data quality assessment in 4 cities, and overall 5% tally sheets was found, only 5% tally sheets was found available. So you can imagine, out of approximate 3,000 sessions conducted in 6 months, only 5% tally sheets were found available during the review. Next slide, please. So same, the availability of monthly progress reports, the 36 number which we can, which is mentioned here, like 36 means 6 facilities data and 6 months. 6 multiplied by 6 months, the monthly progress report compiled on monthly basis. It means a particular facility for 6 months means 36 was the denominator for each and every city. And out of those 36, overall 97% monthly progress report was found available out of 144. Next slide, please. So completeness as the second indicator. Completeness we have considered only for monthly progress report and the HMIS portal as well. And we can see only 51% of the monthly progress report of hard copies were found to be completed. Again, completeness Here I means only the immunization related data fields should be filled in the monthly progress report. Next slide. We can go to the consistency. Like consistency means our data should follow a logical pattern, and you can see both for OPV and Penta doses, only 33% of the reviewed health facilities was found consistent for OPV and Penta. Otherwise, rest all the facilities was not consistent for these OPV and pentavalent vaccine. Next slide. So the agreement means the data in two different sources should match to each other, like from a monthly progress report and HMIS. As I said, the monthly progress report, the primary source of the data entry into HMIS portal, that should be the replica of monthly progress report. But in our data quality assessment, we found that only 76% of the data reported in monthly progress report were found same as in the HMIS portal. Otherwise, that 24 to 25% mismatches were found between MPR and HMIS portal. Next slide, please. So this is the agreement what we have talked about, RCH registers and MCP card. During the community validation, we have found that the data available in the RCH portal for beneficiaries means the dates of the antigens given. Only 81% data which was available in the RCH portal was matched with the monthly with the mother and child protection card, which was found available at the doorstep of beneficiary. So 81% agreement was found between these two sources. Next slide, please. So finally, the observations and recommendations, what we have observed during the data quality assessment, we can show that lack of tally sheet in the reviewed health facilities. Tally sheets were not found. We have, as we seen that only 5% tally sheet was found during the review. So we have made some kind of advocacy to develop a uniform tally sheet. We have shared some form of tally sheet from the health facility, and they have printed that particular tally sheet. And from now onwards, all those 4 cities in which we have done that DQA, all those facilities are using a specific format of tally sheet for each and every sessions. Incompleteness, monthly progress report, what we have observed. So we have suggested that monthly progress report has been reviewed during the monthly review meetings or the field visits, so that that completeness issue can be addressed. For this issue, we have done the capacity building of data handlers and health workers on recording and reporting formats. The third one is inadequate data review and analytics at UPHC level. So we have recommended that timely data analysis and review should be there to ensure all the feedback, to ensure all the completeness and all the error-free data for immunization system. And the last one is issue of agreement observed between the different various tools. So we have suggested that frequent cross-validation of different records and reports should be there, so that that particular issue can be addressed. And we have also suggested for the DQA should be conducted by the state or district health authorities as well, so that the same findings what we have found during our data quality assessment, the same can be addressed or validated by them also. I think this was my last slide. Thank you so much.
Thanks so much, Vishal, for the really interesting presentation. I see we've got some questions in the chat and everything, and so we'll have a chance to discuss those toward the end of today's session. So next, Carmel Toupé will be presenting on MPHD's work to improve data quality in the private sector in Benin. Before I hand it over to Carmel, I wanted to just alert everyone that at this point, our presenters will be switching from speaking in English to speaking in French. So if you have not yet joined an interpretation channel, if you're an English speaker and would like to hear the English interpretation of Carmel's presentation, please click on the interpretation icon at the bottom of your Zoom screen and select English. With that, Carmel, I will hand it over to you.
Ok, merci
All right,
beaucoup.
thank you very much.
Moi,
Zach,
je suis là
me,
pour vous présenter
I'm here to present
un aperçu de la qualité des
a
données
point of view on the quality
qui a
assessment
été
of the project
proposé,
MPHD. That's the Momentum project.
de façon claire, nous allons
In a
présenter
clearer way, we're going to present
et usage.
the usage and practice. Next slide.
Ok,
Okay,
voilà un
well,
peu ce
here,
que ça va être
what I'm going to
dans notre
talk about,
présentation.
our presentation plan.
Premièrement,
First of all,
nous aurons ce qu'on appelle
we're going to have what we call an
et
overview,
également l'engagement avec
as well
les
as
partenaires. Ça sera
involvement with partner
la
centers.
première section.
That'll be the first
Et au
section.
cours de la deuxième section, nous allons
And during the
parler
second section,
et
we're going to
également
talk about
sur
practice
en
and
termes de
the lessons
méthodologie,
learned
en termes de
in terms
méthodologie
of the
et en
methodology,
termes
the
de leçons
results,
apprises.
and in
Nous
terms
aurons
of lessons
également
learned.
une section
We also have
où
a
on va
section.
parler de l'utilisation
We're
des
going to talk
données,
about
ça
using
dit
the data.
l'utilisation est faite des données. Puis nous
So
aurons
the
une dernière session qui va
we're-
un peu
and then we're
parler
going to
des
talk
analyses,
about
les
we're going to
problèmes
talk about the
identifiés, comment
appendices,
les résoudre,
uh,
etc.
identifying problem, how to solve it, etc. Let's go to the next slide.
Donc, comme vue d'ensemble,
So as
nous
overview,
pouvons dire que
we
d'abord,
could say that
faut
at the
rappeler
beginning, we
qu'est-ce
must
est le rôle du système d'information
remember the role of the
qui
information
a pour
system
vocation de quand même faire la collecte, de
and
traiter
how
et
to
d'analyser ces données.
collect and to
Et tout ceci
analyze the
vraiment
data.
pour
But that is all really
faciliter la
to
prise de décision.
facilitate the
Et c'est pour
making
cela,
decisions.
cette raison que
And so that is
les rapports
the reason why
doivent
statistical
être
reports,
complètement
they must be
et en
reliable,
fait
they must be exhaustive,
Nous devons pour
exhaustive,
avoir
and
une cohérence
in that way, we need to
données
have
collectées dans les
consistency
informations
between
sanitaires
the
et
data collected in
également
health
celle de la
facilities
base DHIS2
and as well
qui est le
as the one
poste
in the database,
de stockage des informations.
which is the place
Le
where
but
the data is being
ici,
stored. And the goal here,
c'est vraiment d'améliorer
it's really to
les
improve
dimensions de la qualité de
the
données, à
dimension of
savoir
the
la
data
fiabilité,
quality,
la promptitude,
as well as the
et
timeliness,
l'utilisation des
the
données.
reliability, and the
Nous
data
aurons un peu
usage.
plus de détails dans les
We're going to have
diapositives
more,
qui vont suivre.
we'll go into more detail in the following slides. Next slide.
Ok, ça c'est voilà.
There,
En
okay,
termes
that is
d'engagement
in
avec
terms
les
of the
partenaires,
involvement with
parce
partner
qu'il y a
centers,
en fait
because there is
et
actually,
on lit en tant que organisation
as,
ABMS et les centres
of the
partenaires,
organization
il y
of
a
BMS
un
with the
protocole,
partners,
c'est-à-dire un
ABMS.
accord écrit
And so there is a
qui
written
va
agreement
quand même
that governs
régir
both
les
parties
deux parties
that
pour savoir comment
to know how
définir les clauses de la collaboration.
it's important to define the
L'autre chose,
collaboration
c'est que nous
clause.
avons
Another thing is that
les récompenses des
we
meilleurs
have
centres
the
sur la
rewards,
base
we're
de
rewarding the best
performance.
centers
Et
that
ici,
is
quand on parle de
based on
performance, il s'agit
performance. And we
de
talk about
performance
performance, we're talking about
non seulement
performance,
en termes de statistiques,
not
mais
just
aussi au
statistical,
niveau de la
but also
qualité des
the
services.
quality.
Il y a du fait que
And there also is the
formation
fact that
également
there is
sont
training
organisées
that is
à
organized
l'endroit
at the
de
place,
ces cliniques-là, de ces
at the
formations
clinics
sanitaires-là,
of the data,
formation
health
sur la
data.
FPF, la planification
So
familiale,
there are training on
la
FP, which is family
santé
planning,
maternelle, néonatale et
maternal,
infantile, y comprend
newborn and child
l'information
health,
sur les outils de
as well
collecte.
as data collection
Mais
tools.
tout cela
And all of
est
that,
encadré par une
it has a
signature
framework, it is framed by
prestataire de soins et la
signatures
protection
by health
des données
care providers
consommateurs.
on
Ça
the
sera la
consumer
deuxième
data
fois, nous aurons le
protection
temps
sheet.
de revenir sur ça.
We'll have time to go back to this. Next slide.
Donc, nous allons voir au cours
So we're
de
going to
la
see
deuxième session
during the second session
la méthodologie
the
et
methodology
le déroulement du RDQA,
and as well as the
routine
rollouts of
data
RDQA,
quality
which is routine
assessment.
data quality
Donc, au
assessment.
fait, l'objectif, comme
So
vous
the
l'avez déjà
objective,
dit, c'est
like
d'améliorer
we've already said,
la
is to
qualité
improve
des données,
the quality of data
la qualité des données collectées
that is
pour la prise
collected
de décision
in order to make
des
decisions
données avérées, c'est-à-dire des
based
données
on proven
basées
data. So
sur
those
des
are
évidences.
data based on evidence.
Il y a donc une phase
There's a
préparatoire
phase, there is a preparation
et
phase.
au cours de la phase préparatoire,
And during that preparation
les tâches
phase,
qui sont faites, c'est
the tasks
d'identifier
that are done is
les indicateurs
identify indicators,
et de sélectionner les
and to
sites
select
qui seront soutenus, qui seront visités et de
centers that are going to be
définir
visited,
la période de collecte
to
et
define the
également
collection period,
définir les membres
as well as
de l'équipe
define,
qui seront
identify
concernés.
team members.
Ça, c'est la phase préparatoire.
So that is
Mais
the
nous
preparation
avons
phase.
également
After
une
that,
phase
we have
d'exécution. Et
we have
au
an
cours de la
execution
phase
phase.
d'exécution, on
During this
utilise
execution phase,
un outil Excel
we use a
qu'on
Excel
appelle l'outil RDQA. C'est un
tool that we
outil
call
qui a été
RDQA
développé par
that is
PSI, Population Service International,
that
qui
is
nous permet de vérifier les
that
différentes
allows
dimensions
to verify
que nous
the
avons listées, à
different
savoir la
dimensions,
complétude, à savoir
which
la
allows us to do the
promptitude, à savoir
completeness,
la
the
rapidité également
timeliness
dans la transmission des rapports pour pouvoir vérifier
in
la
the report
qualité de complétion.
transmission, and to verify the quality of
Après
completion.
la phase d'exécution, nous avons
After
aussi
the
une
execution
dernière
phase,
phase, la restitution.
we have a
Donc,
restitution
la
phase.
restitution, généralement,
And
nous
restitution,
formons déjà les
that
prestataires
is
du
to
système
train
sur
the
les symptômes en
providers
matière de manipulation des données.
in terms of the manipulation, data manipulation. Next slide.
Voilà. Là,
Here,
nous avons
here we have,
l'outil qui est utilisé.
this is the tool that we are using.
C'est un
This
peu
tool
différent
is a little bit
par
different
rapport à ce que
in
les
terms
autres
of
collègues viennent de
what
présenter,
my other
parce
colleagues
que
just presented about,
nous
because
avons d'abord ce
we
qu'on
have
appelle
something that is called
l'évaluation de la qualité du système d'information.
so evaluation,
L'évaluation
quality
du système
assessment,
d'information.
data
C'est un
quality assessment.
checklist. C'est un checklist qui est
And it is a
composé
checklist that is made up
d'un certain nombre de questions.
of a number of things,
Nous posons ces questions, nous
of
administrons
questions,
ces
and we ask
questionnaires-là
these questions.
directement à
We
la prestataire
administer
du service
this
qui est visitée
questionnaire that
sur
is
le terrain.
directly to the provider,
Les
the
questions
center that we're
sont
going to
de plusieurs
visit.
ordres.
And
Il
it
y
is a
a, par
different,
exemple,
for
est-ce
example,
que les outils standards sont
the
utilisés?
standard,
Est-ce
one
que
question
sont
could be, are the standard tools
un
being used?
système d'archivage?
Is there a
Est-ce que la
archiving tool?
prestataire
Is the
maîtrise ce qu'on
uh,
appelle indicateur et ce
does
pourquoi
the healthcare
il y a
provider
des informations?
master these
Est-ce qu'il
indicators and
existe
this data?
des fiches de stock?
Are there any
Ce checklist est administré
storage files? And
à
this
la
is
prestataire.
administered, this questionnaire is
Vous allez
administered
voir
to the
il y a une
providers.
légende qui accompagne. C'est un outil
And it is a
automatisé. Dès que vous
Excel
remplissez
tool that is
le
automated.
questionnaire, vous
The
avez
questionnaire,
le score qui s'affiche. Donc, sur
the
l'ex-4,
interpreter,
vous allez voir un score
The interpreter did not hear that.
Donc, ça
So
veut dire
it's going to
86%,
be 86% of the score. That means that
nous sommes
we are
à la coloration orange.
in
Et
the
nous avons
orange
d'autres colorations,
color.
90% et plus, qui est la coloration verte.
So
En
90 or
fonction de ça,
90% or more is green.
l'information
And so
l'information est tirée pour la conclusion.
so based on this, the information is pulled from the color.
Diapo suivante.
Next slide.
Hi, Carmel, I wanted to let you know there's about 5 minutes remaining. Thanks.
Ok, makes sense. Ok, et donc,
And so
pour la suite, c'est que nous avons
Next.
les dimensions de la qualité.
we have the
Qui fait
quality
qu'au niveau
dimension.
de dimension de la qualité, nous
When we
avons,
talk about quality,
plutôt
the
sept
dimension,
dimensions de la qualité.
we have 7 dimensions.
Nous avons la disponibilité, nous avons l'exhaustivité, nous avons l'intégrité.
We have availability,
nous avons
completeness,
la confidentialité, nous avons également
timeliness,
la
integrity,
précision et la
confidentiality,
précision de la
accuracy,
qualité.
and
Donc,
accuracy.
compte tenu du temps qui reste,
So when there is a
je ne
plan,
vais pas
I don't
rentrer dans les définitions,
want to get
mais c'est toutes ces
caught
dimensions-là
up
qui sont
in
quand même
the
évaluées
definitions, but all of
par,
these
la
dimensions are
collaboration.
evaluated
Et toutes ces
and assessed to
dimensions-là
have a
font
score.
partie de ce qu'on appelle la vérification des données. Ça
And
donne ce qu'on
that
appelle
all
la
adds
vérification
to something that is called a verification score. Next slide.
Ok, ça c'est un
So
exemple
this
de la fiabilité.
This is a example of
Ça,
reliability
également dans l'autre étude où nous comparons les rapports
where we
primaires, les rapports sources,
compare the
et les
first
rapports de
report,
synthèse à la base de
the
fiabilité.
synthesis
Et
report
ça nous permet
that
de
is
tirer les conclusions.
that allows
Ce qui
us
est
to
ici,
come up with
c'est
some
que
conclusions when we
l'évaluation était
do that
sur une période
comparison,
de 3
and
mois,
that is over a period of 3
janvier à mars
months
2023.
in 2023. This took place. Next slide.
Ok, donc
All right.
ici nous présentons au fait les
So
résultats.
we are
Les
presenting
résultats,
the
nous avons
results.
les résultats de
With the
11
results,
centres qui sont affichés à l'écran.
11 centers that are on the
Nous
screen.
avons au fait les 7 dimensions,
So we have 7
les
dimensions,
dimensions qui sont représentées.
the
Donc là,
dimensions that are
ici,
represented.
ce qu'on peut faire, c'est que c'est bon.
You see that when it's open,
Ce
it's
qui est
good.
attendu ici, c'est un
And
score
so
de
what
90%. Ah, ça
we
veut
were
dire que c'est
we were hoping to have a
90%,
90%
ça veut
result.
dire que on doit
And so if there's a
voir ce qui
90%,
ne va
then
pas à
if
ce
this
niveau-là. Et dans l'exemple, nous avons vu qu'il y avait un problème au niveau de la promptitude.
the interpreter is having trouble hearing because the speaker just cut out. Sorry.
OK. Et
All
là,
right.
ici, nous avons au fait le score global.
So
Nous avons
we
la
have a global
vérification
score.
des données
We have
et nous
the
avons
data
l'évaluation
verification. We
du
have
système. Donc,
the
l'évaluation
system
du
assessment,
système ici est à
and the
87%.
system assessment is at
Le score de la
87%,
qualité
and
ici est
the
à 92%.
quality is
Et donc, ça
92%.
nous a permis de conclure 97%
And that allowed
pour
us
la
to
vérification des données.
conclude that data verification was 97%. Next slide.
OK. Les leçons
All right.
apprises, c'est que
So what we learned
nous avons quand même
is that we
forte
have
implication des statisticiens
a strong
parce
involvement
que
of
on
health
ne fait pas
zone
ça seul
statisticians
et ça aide
because
à l'intégration des cliniques.
that
Nous
helps us
avons
integrate the
également
clinic.
un suivi rigoureux
And we also have a
recommandation de
integration of the
qualité.
clinic at the clinic. And there's a rigorous follow-up
Comme
of
leçon apprise, c'est
recommendations. And
que
so it's challenges
le
addressed.
partage des
And the other thing
résultats
that we learned was that the sharing of the results or of the RDQA,
directement à l'amélioration
it
du
takes us
système de
actually to
suivi
the
évaluation.
improvement of the monitoring and evaluation system. Next slide.
OK. En ce qui concerne l'utilisation
And
des
so when
données
we talk
cliniques,
about the
l'utilisation des données
usage
est
of
avant tout
the data, it's
informer
really
le
for
projet
It's for telling about the project. So we have sessions, D2A, data to action. And that is to highlight the gaps and ask the data, ask about what can we do with the data to be able to make corrections. We also have learning workshops on the implementation of the project. And that during these instances, we share out, and as well as direct feedback, which allows us to follow the management of the follow-up of RDQA recommendations, as well as during RDQA missions. Next slide. Next slide. So the challenges that we've faced, it is the application of the RDQA, and what has been presented was the Excel, which was already used. And they have put some parameters. The tool is direct. So it is to start to use it, and that will facilitate the process. And the other one is so the use of RDQA applications, as well as do an evaluation of a higher number of health facilities. Because the challenge is really to go to more clinics. Next slide. And so we're going to go into review the appendices.
Here you see the problems that were identified. For each problem, we have a specific action. For example, we said that there was issue with being on time, meeting the deadlines, and here the health centers managers are responsible for that. So those are the kind of recommendations we provide. Next slide.
Carmel, we will need to conclude in just another minute, so we have time to answer a few questions. Sorry to interrupt.
We also have a plan for recommendation, to follow recommendations. Those are the recommendations that we showed previously in the matrix, but here we use a specific score and the next deadline for when it's not achieved. Next slide. This is the last annex, is the protection card for the consumer established by PSI. It helps us to protect the data of the consumer, since we have to protect them. We have sensitive data, so it helps us to make sure that we respect the data confidentiality, sharing data and saving data. So the health provider are trained in this regard, and they need to make sure that they respect those engagements. This is the end of the presentation. Thank you for your attention.
Thank you so much, Carmel. And thank you to both Carmel and Vishal for those wonderful presentations, very comprehensive, a lot of really useful information. We have done our best to answer as many questions as possible in the chat and in the Q&A section, given that we don't have a lot of time left for questions. But I wanted to ask just a few questions, maybe one to each of the presenters. Vishal, I saw there was a question in the chat asking about why you reviewed 6 months of records as opposed to a complete 1 year of records, and was wondering if you could respond to that one. Oh, and I think you're on mute.
Sorry. So we can review the 1 month data as well, but for maximum use of human resource, maximum utilization of human resource, and availability of time during the data collection, as we have got the huge number of beneficiaries in a particular single month, and we have collected the data for 6 months. But no, in that case, we can also collect the data for 1 year also. But during the data collection process, we have found that data collection is taking so much time, and after that, we have considered for 6-month data collection in place of 1 year data. So, but we can also collect 1 year data as well for this data quality assessment process. No issue on that. The major concern was best utilization of the human resource in the given time frame.
Right, absolutely, that makes a lot of sense. Thank you. And I think given time constraints, I'll ask one last question to Carmel. I think most of the questions in the Q&A have been answered, but I wanted to just ask from my own perspective, what are, in your opinion, Carmel, the biggest data quality challenges that private healthcare facilities face?
Merci, Emily.
Thank you, Emily. The biggest challenge is that we have problems of timeliness. So timeliness is, and so that's the challenge that we have, but we are addressing them because, like the sessions, the feedbacks, where we can learn things, it allows us to go back to these points and work on this.
Great. Thank you so much, Carmel. And thank you to both presenters. I will turn it back over to Zach to close us out. Thanks, everyone.
Thanks, Emily. So just in conclusion, we want to thank you all very much for joining us today during our session. I think it was we had some very interesting questions and engagement in the chat, so I was very happy to see that. And thank you very much to our presenters for the insightful and interesting presentations. Before we close today, we just wanted to remind you all that the next session in this series will be on data triangulation and analysis, and that will be held on September 5th. So thank you once again to our presenters and to all of you for joining us today, and we hope to be in touch with you soon.
Thank you. Thank you, Zach. Thank you, everyone.